On behalf of the American Heart Association, I'd like to welcome you to today's webinar, Announcing Target Type 2 Diabetes Ambulatory Recognition. My name is Liz Olson, and I'm the Senior Quality Programs Manager for the American Heart Association. I'd like to begin by going over a few items so you know how to participate in today's event. If you'd like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. At the conclusion of today's presentation, you'll receive a link to access today's recording, as well as an invitation to complete our feedback survey. We welcome you to submit text questions for our presenter at any time in the questions pane of the control panel. We'll collect your questions and address them during the Q&A session at the end of today's presentation. It's my pleasure to now introduce our speaker for today. Dr. Dana Weisshaar is an advanced heart failure transplant cardiologist at Kaiser Permanente in Santa Clara, California. She has local, regional, and national responsibilities for oversight of transplant quality for the organization. Dr. Weisshaar is a previous member of the board of directors for the Silicon Valley chapter of the American Heart Association and currently serves as a volunteer member of the American Heart Association's Ambulatory Quality Advisory Group. It's my pleasure to now turn today's presentation over to Dr. Dana Weisshaar.
Hi, thank you very much. I welcome all those in attendance, and I appreciate your attention today. I am excited to present I'm sorry, I'm having troubles advancing now. Sorry, the Know Your Diabetes by Heart Ambulatory Initiative. So the American Heart Association and American Diabetes Association have launched this collaborative initiative called Know Diabetes by Heart as a comprehensive way to combat the national public health impact of diabetes and cardiovascular disease. This collaborative initiative raises awareness and understanding of the link between diabetes and cardiovascular disease. It empowers people to better manage their risk of cardiovascular disease, heart attack, and strokes. And it supports healthcare providers in educating their patients who are living with type 2 diabetes. Although some progress has been made in the recent decades, the national public health impact of cardiovascular disease is still tragically high. It's a leading cause of major complications such as heart attacks, strokes, and disability for patients living with type 2 diabetes, and yet less than half recognize that risk. Problems too big for any one organization to address, which is why the AHA and the ADA have partnered and are happy with the support from the founding sponsors, Boehringer Ingelheim, Eli Lilly, and Novo Nordisk. So this initiative is aimed, as I mentioned, at reducing cardiovascular deaths, heart attacks, and strokes, as well as heart failure in people living with type 2 diabetes. The initiative has a broad approach to tackling CVD and type 2 diabetes, and it touches on many facets of the AHA and ADA's organizational structure. Today, we're just going to focus on clinical quality improvement and the science behind the drive for this initiative. It's important to know that the Know Diabetes by Heart is working from multiple angles to address public health impact through consumer messaging, policy, and education, as well as the clinical piece we're going to talk about today. Oops, sorry, touchy computer. This initiative, goodness gracious, sorry. This initiative, as we dive in and look at just the high level, looks at consumer activation in terms of understanding patient education, resources for providers, as well as professional education and resources and quality improvement. As I mentioned today, we're going to be looking at specifically the ambulatory quality piece for information on the inpatient portion of this initiative, as well as the honor roll. We won't be discussing those today, but there are 2 previous webinars addressing that part of the campaign that can be viewed on the knowdiabetesbyheart.org website. Lastly, I'll mention that Diabetes Inside is an American Diabetes Association program that focuses on intensive quality improvement projects in selected healthcare systems and is already closed to new participants. As I mentioned, the target type 2 diabetes inpatient piece and honor roll have already been addressed in previous webinars, and these are available for your viewing through the knowdiabetesbyheart.org website. For today, I want to focus on the science and rationale behind our ambulatory part of this initiative. So why does it matter? Cardiovascular disease is the leading cause of death for people living with type 2 diabetes. In fact, patients with type 2 diabetes are twice as likely to develop heart disease and to die from cardiovascular disease. Yet, in a recent poll, only half of patients with type 2 diabetes understood that risk of developing heart disease. When we look at the impact, we can see that in blue, the non-diabetics compared to the diabetics had a higher rate of mortality, both in men and women. And if we compare at age 50, on average, patients with diabetes live 6 years less long than those without diabetes. The majority of that early premature death is related to vascular disease, a higher rate of cancer, and then 30% due to other causes. For comparison, that reduction in life expectancy is only slightly less impacted than if we look at cigarette smokers versus non-cigarette smokers, where the average difference in life expectancy is 10 years. Now, if we flip the colors on the graph and we look at diabetics in blue now versus the non-diabetics in red, we can see that for all-cause mortality, we've made improvements over the last couple of decades in terms of reducing all-cause mortality on the left and cardiovascular mortality on the right. However, despite those improvements over time, there's still a disparity, which here we've labeled residual risk among the diabetics. So diabetics have a higher overall mortality as well as a higher risk of cardiovascular mortality. And sadly, that impact is even higher for women than it is for men. When we account for age, weight, and other comorbidities like hypertension, we still see a higher incidence among women with diabetes who develop heart failure, limb ischemia, stroke, and heart disease. Now, I'm a heart failure cardiologist, so I'd be remiss if I didn't also point out that among patients with diabetes, heart failure of all types, heart failure with preserved ejection fraction, mid-range ejection fraction, and reduced ejection fraction, all have worse survival if the patient has type 2 diabetes compared to those who have no diabetes. And sadly, the prevalence of diabetes is increasing, not just in the United States, but across the globe. In the US, already 1 in 11 Americans has diabetes, and 1 in 2, or 50%, have prediabetes or diabetes. Type 2 diabetes accounts for 90 to 95% of all the diabetes in the United States. So a program like this can have a huge impact. And as the diabetic population across the globe increases over the next 25 years, we can see that our opportunity to impact survival and reduction in cardiovascular risk grows. Just to show you how alarming or deadly this condition is, we look at a graph like this that says in the United States, diabetes contributes to a stroke every 2 minutes, a heart attack every 80 seconds, and the risk of kidney failure every 10 minutes, and loss of limb every 5 minutes. So the impact is already enormous in this 2017 report, and it's only growing since the rate of diabetes is growing across the globe. Worldwide, 1 person dies every 8 seconds from diabetes and its complications. The recent US press has been very focused on our opioid crisis, and not to diminish the importance of those efforts to reduce opioid dependence, but compared to diabetes, it's a big difference. Patients die from opiates every 52 minutes compared to every 8 minutes from their diabetes. Another way of showing the severity of the problem in the United States is a graph like this that shows nearly half of all adults have hypertension. 34% approximately patients have prediabetes, 12% already have diabetes, and 40% have hyperlipidemia. And that's just the patients we know about. This study over a couple of decades shows that we know about diabetes in about 70% of our population, but there's a third of patients who are unaware and therefore untreated for diabetes or prediabetes. Even among the 70% of patients who we do know about, less than 20% in general are adequately controlled. So there's a great deal of work to be done to improve our care for the diabetic population, recognition and care. Patients don't come just with a single diagnosis often. About 25% of Americans have 2 or more chronic conditions. As we pointed out, hypertension, hyperlipidemia, diabetes are among some of the most common in the United States. And when we start combining these, we combine the risk of mortality as well as worsening functional status, higher hospitalization utilization, and we start running into issues of adverse drug events. And if we have more than one physician treating more than one condition, we might end up with duplicative tests, which increases our healthcare expenditure, as well as conflicting medical advice. We spend 66% of our healthcare dollars on approximately 27% of Americans, primarily because of the multiple chronic conditions. This graphic is another way to show that fewer patients come in just a plain single diagnosis variety. The blue bars do show those patients who have just diabetes or just cancer or just heart failure. However, patients with 2 or more other conditions is particularly high among patients with chronic kidney disease, lung disease, and you can see also heart failure. So I want to spend a little bit of time today to focus on what we can do in an ambulatory care setting to affect that risk of cardiovascular events in our diabetic patients. So if we look at a group of diabetic patients pooled from several different studies, we can see that the percent of patients with blood pressure adequately controlled in 2018 was less than 50%, only 41.8%, and only a third of patients had an adequately controlled LDL cholesterol, and less than half had their diabetes controlled. And then if we look at it a different way, we can see that of those patients, 41% had one of those 3 conditions controlled, and only 7% had all 3 of their risk markers adequately addressed. There's a lot of opportunity there. If we can control those risk factors, here's what we can do in terms of reducing the risk of cardiovascular disease. By controlling blood pressure, we can reduce cardiovascular events by 17%. By controlling lipids, we can reduce that risk by 1/3. And by controlling the hemoglobin A1C, we can get a 37% reduction in the risk of cardiovascular events. And if we control just 2 of those 3 risk factors, we can reduce events by half. And if we can control all 3, we can reduce by 62%. So an initiative like this really brings the power of the American Heart Association, the American Diabetes Association, and our best current science together to really impact large swaths of the population who are struggling with diabetes, and we can reduce their risk of heart disease, stroke, limb ischemia, as well as death. Now, this slide just shows that the vast majority of that heavy lifting in terms of hypertension control, hyperlipidemia, chronic kidney disease management, and diabetes falls on the shoulders of our primary care physicians. Put another way, in 2016, this is our most current data, heart disease is still the #1 killer among adults in the United States. Stroke and diabetes add up to a substantial percent of the top 10. So for this initiative, we're going to focus primarily on how do we manage the diabetes in these patients. Other initiatives for the American Heart Association have focused on hypertension control and hyperlipidemia, and specifically No Diabetes by Heart is promoting better management specifically for the diabetic population. So here's a consensus report from the American Diabetes Association and the European Association for the Study of Diabetes. It focuses on understanding individual patient level issues regarding lifestyle, their other comorbidities, their current hemoglobin A1C, their weight, as well as comorbidities and of depression and their motivation to change. It also takes into account the cultural and socioeconomic context in which the patient lives. It looks at specifically choice of treatment based on patient comorbidities and focuses on patient engagement, because we can't make an impact in the well-being of the patient without their cooperation and partnership. The latter part of this cycle points out that it's not one and done. We need to implement a management plan and continue to monitor and support patients to continue to improve. Taking away some of the specifics on the slide, again, I want to point out we're talking about specific factors which influence the treatment choice. We're going to go through this carefully, talking about shared decision-making, agreement with the patient on a plan, we implement, and we continue to monitor to make sure we reach our goals. Now, step 1 is to identify among the diabetic population whether or not patients already have atherosclerotic vascular disease or heart failure and CKD already, or neither of the above. you'll see at the top here that the overall approach begins with metformin and a comprehensive lifestyle assessment, which includes diet, weight management, physical activity, and as I mentioned earlier, focuses on modifying treatment and evaluating the effect regularly every 3 to 6 months and not accepting failure, but continuing to work together with the patient to improve their outcomes. In patients with already known atherosclerotic vascular disease, we want to focus on using upfront either the glucagon-like peptide-1 receptor antagonists that already have proven CVD benefit, like liraglutide, semaglutide, and dulaglutide, or choosing the serum glucose cotransporter 2 inhibitors, specifically those that have proven cardiovascular benefit, like canagliflozin, empagliflozin, and dapagliflozin. If the hemoglobin A1C, when we reassess at 3 or 6 months, is still unacceptably high, then we add additional agents. So if you choose this one, add this one, or vice versa, and consider adding other agents based on the response to the patient for their hemoglobin A1C. If they have heart failure, we specifically want to start with the SGLT2 inhibitors. And we want to make sure we avoid the thiaglitazones. So we've talked about patients who already have established atherosclerotic disease or kidney disease or heart failure. What about those patients that we already talked about who don't have known vascular disease but do have diabetes that's inadequately controlled despite metformin and lifestyle modifications? I think this is going to pop up. Yes. So this busy little slide says it doesn't really matter which one of these agents you choose. You can use the serum glucose cotransport 2 inhibitors or the glucagon-like peptide-1 receptor antagonists, as we did in the patients with known vascular disease. You can also use the dipeptidyl peptidase 4 inhibitors or the thiaglitazones. All of them, though, need to have a reassessment of your hemoglobin A1C target, and then you start adding additional layers until you get to adequate control. And the ADA is now focusing on the initial injectable, rather than going straight to insulin, should be the GLP-1 receptor antagonists. Other considerations are if you have a compelling need to minimize weight gain or promote weight loss, you may want to come back to a method that focuses on the GLP-1 receptor antagonists or the SGLT2 inhibitors, as outlined here. And the final consideration they've included is a cost, which is a major issue for patients. If you have someone who has cost as a barrier to their controlling their disease, they're only going to be able to take the medicines they can afford. So we need to consider what the patient's impact of cost is in their ability to manage their disease. These newer agents, the SGLT2 inhibitors, the GLP-1 receptor antagonists, etc., are more expensive than the sulfonylureas, are more expensive than insulin or the TZDs. So if we need to use a less expensive agent for patient compliance, the goal is ultimately still to get their hemoglobin A1C under better control. So I want to wrap up by this call to arms. Patients with diabetes are at high risk of atherosclerotic heart disease, kidney disease, and heart failure. We can influence that risk by better control of their diabetes. And we can do so by changing our practice to introduce GLP-1 receptor antagonists, or SGLT2 inhibitors, as earlier lines of therapy in patients with atherosclerotic heart disease, and specifically in patients with heart failure, use the SGLT2 inhibitors. Patients with CKD as well can have a significant improvement through this management strategy choice. These are major changes in the recommendations for treating diabetes. They're informed by new evidence generated in the past 2 years. There's still a great focus on lifestyle interventions with an increased emphasis on weight loss and obesity management, including the use of metabolic surgery. And the medication choices are moved to using the GLP-1 receptor antagonists as the first injectable prior to using insulin, and using the glucose lowering agents that now have been shown to have a specific impact on cardiovascular health. This is a living document, and updates have been incorporated based on the new data and will continue to be updated as new data becomes available. Thank you. I believe that's the end of my time. I hope I've inspired you to improve recognition of diabetes and recognition of cardiovascular disease within the diabetic population, and to improve or incorporate these new recommendations to improve the outcomes for this population. With that said, I am excited to be partnering with the AHA and the ADA to launch this Target Type 2 Diabetes initiative to help with those improvement goals.
Thank you so much, Dr. Weisshaar. We really appreciate your time and thoroughness with this background. I think it really speaks to the information that I'm about to present around our recognition initiative. So I really appreciate your time. This is Catherine Overton. I am the Senior Manager for Ambulatory Quality here at the AHA. The next amount of our time is going to kind of be spent walking through the new Target Type 2 Diabetes Ambulatory program, as well as our recognition components. This is just kind of the beginning of our journey here. So thank you all for joining to listen in, but please know we're going to be sharing a lot more information about how to participate in this initiative in the very short order. And hey, Liz, I think, there we go. I can advance now, thank you. So, first and foremost, what is Target Type 2 Diabetes? You heard Dr. Weisshaar mention that we have an inpatient offering that is working with our Get With The Guidelines participating hospitals. We now have this kind of complementary program that is focusing on ambulatory organizations. This is a quality improvement initiative and an annual recognition opportunity by the No Diabetes by Heart initiative that is supported by the American Heart Association's regional staff. This new program, Target Type 2 Diabetes, leverages all of the great resources and education that come out of the No Diabetes by Heart initiative, combined with our regional staff to help support outpatient organizations who wish to tackle these really troubling issues around type 2 diabetes and CVD risk factors. Recognition is an output of an organization's participation in the initiative and should encourage and incentivize participants to register, improve, and engage with us. So while we're going to be talking about the recognition program, I want to make it clear that there's a lot more to this than just, an award opportunity. We really do want to engage with you on a local level. We want to be able to support you in your journey as you begin to kind of untangle all of these pieces of this comorbid condition. So, what you'll be able to do is we're going to talk about how you can register for the initiative, how you're going to submit data year to year, and how you're going to engage with us so that you can improve and make sure your patients and community know the good work that you're doing. So first and foremost, I want to talk a little bit about the benefits of recognition. I'm going to kind of sequentially walk through the process of how you'll register, what recognition entails, and what the resources are that are going to help you improve. But right up front, the benefits of recognition are beyond, obviously, some of these more tactical informations, but, really improving the lives of your patients, digging down and making improvement in processes that are hopefully going to drive care, drive process improvement, maybe hopefully find ways to make your workflows a little more concise, but also, really hopefully add some acceleration and momentum behind your work. So we hope that things like an award certificate and digital icons that will allow you to promote your good work, and things like press releases, social media messaging, and communications are all ways that we want to help you publicize how great you're doing and everything that you're doing to dig into this problem. We will be recognizing nationally all those organizations that qualify for our recognition program and giving them mentions at scientific sessions. So this is, if you don't qualify for recognition, we want you to still engage with us. We want you to still register. We want you to still try to submit data and get there, because we think that this is a journey and not just, an end game. So an overview of recognition, and I wanted to start right up front with this because I know this is what a lot of people are really waiting to hear for. Recognition is going to feel very, very similar to our other programs like Target BP, like Check Change Control Cholesterol, if you're familiar with those programs. It's got a kind of a 1, 2, 3 punch that for organizations to, one, register, and you're going to do that at nodiabetesbyheart.org/quality and navigate to our ambulatory section. So then once you're all registered and you have your data submission criteria and your login credentials for our data submission platform, you're going to submit organizational information and do a self-assessment to really help you understand where you might have gaps in your care. And this is very guideline-based. We've actually, I'll show you some of the questions that we ask, and we've really tried to stick, even with kind of the cadence of information that is provided by the guidelines. And then the second part is a numerator denominator aggregate measure submission. And so what that means is we're not going to ask you to submit patient level data to us. We're going to ask you to say, of my diabetic population, how many are being treated a certain way? And we're going to put some thresholds and parameters around that. So we hope that this feels familiar if you're in some of those other programs like Target BP or Check Change Control Cholesterol, although we do have some switch-ups for you. So those 2 award levels that we're going to be offering this year, you'll be able to get them for the first time in 2020, the first is a participant award. It is going to be for those organizations that complete all parts of the data submission process, including measure submission. So that is, steps 1, 2, and 3. And then the gold award is going to be for those organizations that meet the threshold of participants. So they've completed everything, they've submitted the measure information, but they also meet the specified threshold for the measures. And we'll dig into what those measures are here real soon. I do want to call out that eligibility for this program in data submission is really for those organizations providing direct patient care. So you need to be able to track your patients, whether it's in an EHR or some type of registry, and you need to be providing patient care in those follow-ups that Dr. Weisshaar mentioned around improving that actual patient in their clinical journey. So this is, if you are not an organization that provides direct patient care, maybe you're someone like a Department of Health who doesn't actually have, patients seen in a clinic, you're just an an agency body, we still really would love for you to register for our initiative, because we will be sharing a lot of important resources, education, science, collaboration opportunities in our kind of newsletters and things like that, that will really be useful and informational, even if you don't qualify for the awards. So again, I do consider everyone to register, or consider everyone who's interested to register. I think that there's just going to be a lot of great information that's coming out of this initiative, regardless of your opportunity to be recognized. So let's talk about registration. Step 1. This is, again, should feel really familiar if you're familiar with our other AHA programs. But what's new is we now actually have a combined registration. So starting today, actually this evening, you'll be able to register for 1, 2, or 3 of our programs. If you're just interested in target type 2 diabetes, please just go register in that program. But I wanted to call this out because if you maybe are registering in target BP and you can now register for target type 2 diabetes at the same time. Previously, all of our program registrations had different places that they lived, and you had to fill each one of them out. So I just wanted to call out this little shift and change. The questions are familiar. It's a pretty simplistic registration process that requires a acceptance of a program agreement. But what you'll be entering is your contact information. We want to understand your total adult population count. How many of those patients are a race other than white or identify as Hispanic or Latino? How many clinic locations do you have in your health system? If you're just one location, that's great. If you're a really large system, that's great too. You can actually register multiple ways. You can register as your system overall. You can register in each individual location. But I will say, if you are a really large system, 25, 30 locations, and you want to register all of your individual locations, please don't fill out the Form 25 30 times. We have a separate process that we can do to help you accomplish that goal. Just reach out to us with contact information. Last thing you'll need to know is things about your organization characteristics, like are you in a federally qualified health center, multi-specialty, are you maybe rural health, things like that. So please go in and register. One thing I will mention is that if you are already participating in check change control cholesterol or target BP, you will get an email confirmation welcoming you to the program, but you may not get information on our platform, our data submission platform and login credentials, because your organization already has an account. And if you have issues accessing that account, we can certainly help you with that. But I hope that the email communications that you receive when you register should help you navigate that process. Okay, next part is the data submission part 1, and this will take place in our data submission platform after you register and you get access. And after January 1, 2020, this process will begin. And I say after January 1, 2020, it's because we want you to complete these assessments and all of the measure information in accordance with the 2019 calendar year. So you will be submitting data regarding the 2019 calendar year for recognition in 2020. So you can't accomplish that goal correctly if you're starting before the end of the year. So for part 1, there's kind of 2 sections in part 1. Is we're going to be asking you, again, some questions about your organizational mix. So your patient population, your race and ethnicity makeup. We're adding some new questions around payer mix and total number of providers. And really, these questions are less about, improving or, getting recognized or not. These questions are to help us service you and your organization so that we can help build resources around your patient population, and we can provide staffing at the AHA side that matches your resource need. The second part is, again, less about receiving recognition or not, and more about understanding where you as an organization are in an improvement journey. And I'm not going to cover all of these questions specifically. We will be creating a larger data submission kind of worksheet that will help you work through some of these questions that will be available probably before Christmas. But there are these kind of 4-ish questions that ask about your protocols for assessing patient characteristics and what does it include, how your organization operationalizes treatment plans and what that includes, and then how do your organization track patients. And then, again, this is really about understanding you, helping you understand you, and helping our staff help you find gaps in the problems and processes that you have. So there are no right or wrong answers. If you don't have a specific component of one of the questions, that's okay. You can still be recognized, but we wanted to call out gaps that you might have in case that was an easy place for you to go and make some improvements. And then lastly, we have a question related to organizations committing to continuously improve. And we just want to know that you're in this with us together. And so we do require a yes response for recognition. All right. I think this is the slide that everyone is waiting for. This is the measure submission part. There's a lot on the slide, so I'll go slow to decode it. But I do want to reinforce that this section of the program is required for recognition. In our previous programs like Target BP, Check Change Control Cholesterol, the participation award or participant award was really, you didn't have to submit the clinical measures necessarily. You could, if you didn't meet the threshold, you were still a participant, but you didn't necessarily even have to submit them. We are changing that in this program and actually in all of our programs. So for all of our programs, you have to submit the measured data, numerator and denominator, that goes along with these programs for a participation award. And again, even if you don't hit that gold mark, we want you to be starting your journey and assessing your baseline, understanding where you are with these measures, where you might be seeing trends, where you might be seeing patients falling out of compliance. Maybe they're not controlled in one measure or another. It's so important when you're starting an improvement journey to know where you started. So that's why we're requiring this. Okay, so for the measure submission component, in Target Type 2 diabetes, you are going to be required to submit numerator and denominator information for 2 total measures. All participants must submit the hemoglobin A1C greater than 9 poor control measure, and all participants must submit either the statin for prevention and treatment of cardiovascular measure or the controlling high blood pressure measure. You can pick either one, but you have to submit at least one. If you want to do both, great. We think that is great, but we felt that the threshold for everyone being able to do all 3 was possibly a little high, and we wanted to make sure that, you know, this first year we are bringing people in and helping people start. Now, don't be surprised if in the future we do change this and we require multiple measures, but for now, 2 total. 1 has to be the diabetes measure, and then 1 has to be one of the 2 CVD measures. And that's for participant award. For gold award, you have to meet the threshold of the measures that you pick. So everyone has to meet the annual rate of 25% or less of your patients in poor control for the diabetes measure, and 70% or greater in either of the CVD measures, statin treatment or controlling high blood pressure. So again, diabetes, less than 25%, and this is what we call an inverse measure, and that it actually focuses on the patients that are doing poorly. So less than 25% of your patients can have a poor control of less than 9 in the hemoglobin A1C, and statin treatment or high blood pressure annual rate of 70% or greater is how you're going to hit the gold mark. Well, again, if you can't hit these marks, This is the start of your journey, and we encourage you to participate at the participant level because we want to help you get there. Now, there was, on that last slide, there were a lot of numbers that were sitting next to each of the statin measures and blood pressure and diabetes measure. These are, and actually I'm going to go back and show you that slide one more time. These are MIPS number 1 and QS59 is our diabetes measure. MIPS 438 is our statin measure. And then the MIPS 236 or NQF18 is the controlling blood pressure measure. And then I'll show you this next slide again, which has even more numbers. We specifically selected these measures because they are some of the most ubiquitous measures related to these care conditions in the nation. They should be on everyone's mind. We specifically wanted to align with measure authoring bodies like CMS, like NQF, because there's a lot of information and resources out there about these measures. These three little tables here, I've pulled them directly from the Quality Payment Program website that lists, all the other different numbers. So if you're familiar with these measures in a different realm, maybe you are doing ECQMs, those numbers are there and available for you. Or if you're familiar with, simply calling them the NQF or the MIPS quality ID numbers, those are there as well. So these measures, again, are very ubiquitous. They're actually the same measures that are part of the UDS for the federally qualified health systems. They are the same measures that are in several of the payer programs. And so we thought that if we continue to use these measures, one, like I said, there's a lot of information out there by really great agencies like CMS to help you understand these measures. And two, if we could pick measures that your organizations were already being measured on and maybe being paid upon, then that would be a good motivator to do so. A little bit more about why we chose these measures. So there is a lack of measures that target type 2 diabetes and CVD specifically. These are nationally endorsed, widely available, and we wanted to create something that was flexible. We also didn't want organizations to be spending all of their time trying to figure out how to run measures and novel measure queries. We hope that hopefully somewhere in the back of house, these queries are already written and available. And I do want to call out that all the measures should be calculated specifically to the National Reporting Year specifications by the primary measure steward, whether that's CMS, NQF, and CQA. ECQMs or registry specifications are acceptable. However, it needs to be by the national standard without deviation. Okay, so register. This is your recognition timeline. The first thing we want everyone to do is go out and register. You should be able to do that by this evening. We're turning over our websites right now, so this new registration is available. So go out and register. Get set up with your data submission platform account if you don't already have one, or figure out how to get back in there, reactivate your account if you need to. Starting January is when the data submission will begin. All the program data forms, whether it's blood pressure, cholesterol, diabetes, will all be together in the same platform, and they will all be available beginning January 1. Make sure you're listening and out for your newsletters. We have data submission trainings that we'll be doing, office hours to support data submission throughout the data entry period. And obviously, we'll be doing a lot of educational promotion and engaging with the AHA staff. Data submission ends May 29th at 11:59 p.m. It has a p.m. in there, Eastern Standard Time. This is a Friday. What happens is on May 29th, we will take a snapshot of the platform data, and that's what we will use for recognition. So if you go in on January 5th and enter your data, and then you need to make modifications on May 25th, that's fine, as long as what's in there at May 29th, 11:59 p.m. Eastern Standard is right. That's what we will use for recognition. After that period of time, you can edit your data. However, we cannot accept it for recognition. So please make sure that you're ready and done by May 29th. Over the summer months, we'll be finalizing our award listings. We typically announce awards in September, And then we'll want to be make sure that you're preparing for 2021 submission, because holy moly, you know how fast these years go nowadays. It will be here in no time. So I wanted to, again, just kind of point out a slide that Dr. Weisshaar presented at the very beginning about how Know Diabetes by Heart is a really large activation campaign. There are patient components, there are consumer components, such as social media presences. There are a ton of professional resources and education, as well as our quality and systems improvement work. So please, do a little digging. We'll do our best to kind of start to decode this for you over the next couple of months. But encourage you to go to that Know Diabetes by Heart website and take a look at everything that is there, because we have so much available. Because this is really the start of your journey, I hope. Hopefully it's not the very beginning. Hopefully you're already looking at some of this information, but I hope that we all can get together and really dig in. I wanted to do a quick slide about some of my favorite resources, honestly. In our health professionals resources, we have a great guidelines pocket guide that covers a lot of the emphasis on weight and lifestyle modification, as well as some of the prescribing algorithms. The podcast series, if you're an avid podcast listener, these are really, really great. I'm really enjoying them. I think there's at least maybe 10-ish of them now. Very succinct and very helpful and useful. We have a full educational webinar series, of course, all the scientific guidelines and statements, and our professional decks. There are patient education materials in both Spanish and English, as well as patient programs that you can engage in. And then we will be coming out by the end of the day. Again, we're having some issues with our website, but by the end of the day, you should have things like a recognition fact sheet, a frequently asked questions, a registration support document, which is a full text of our registration, so you can prepare for that. We also have a clinical change guide and a health system rollout guide that we can provide to you, and then we'll be coming out with a data submission worksheet. Lastly, I wanted to call out a new app that we've just developed. It's called A1CVD Pro. I just downloaded it the other day. It's brand new. It's really neat. It is a mobile app, obviously, iPhone, iPad, Android, whatever, competency-based medical education aimed at primary endocrinology and cardiology. And it uses real-life case studies that you kind of can play along with in a gamified way to simulate a specific patient and a treatment protocol, and it kind of guides you in that journey of treating the patient and the follow-up process. So really great way of tackling some of this education, and I highly recommend it. All right, 5 key takeaways, and then we're going to try to do 5 minutes of questions. Register now. That's the best way to stay connected. Know Diabetes by Heart/quality. And then you're going to look for that ambulatory section in the register. Again, that might not be up right now, but we're hoping it'll be up by the end of the day. We also have a survey that will come out after this webinar that will also have a recording of this webinar. I hope I'm saying that right. But please take our survey, help us understand you and how we can create a better experience. If you're an existing AHA program participant like Target BP, Check Change Control Cholesterol, expect a similar experience in the registration and data submission. I know this is new, but we've really created this in a way that it's streamlined and makes sense for you. Recognition does require numerator, denominator, measure submission entry for the 2 measures, diabetes and 1 of the 2 CVD measures. Data submission begins January 1st and ends with that snapshot on May 29th at 11:59 p.m. Eastern Standard Time. You can edit your data anytime, as long as it's right, that midnight almost at May 29th. And please join our platform trainings, office hours, and leverage your regional staff person for assistance. And then if you have questions, please contact us. We have the website. We also have this bit.ly link, AQ Contact Us, and that is case sensitive. That will help you connect to your regional staff, because that goes straight to your regional areas, as well as a general target type 2 diabetes at knowdiabetesbyheart.org email address. All right, let's do some questions. Liz, are you available to help us with questions?
I sure can. Let's see here. Do you know if we offer any CMEs for any of our education?
So that's a great question. This webinar itself does not offer CME. Several of our initiative webinars do not. However, both the ADA and AHA collectively have a lot of CME opportunities in both of our organizations related to this subject. So I would encourage you to seek those out, either depending where you're really trying to hone in, either with the ADA Professional Sciences or the AHA Professional Sciences. And if you have any issues finding those, just let us know and we'll help you get in the right area.
Okay, great. Can you clarify how sites should register if they already have an account with or are participating in Target BP or Check Change Cholesterol or some other ambulatory program we offer?
Yeah, great question. So essentially what's happened is all three of our programs are now in a combined registration form, but they act the very same way. So if you're already registered, you're still going to go register, and there will be a question, as in like a pre-question, about what you're already participating in. And you'll just kind of check those boxes. It'll ask you what you're already participating in and what you'd like to register. And then from there, the registration kind of curates the questions. It's not going to populate your existing registration data, but it will make sure that you're not getting questions related to programs you've already registered for. And if you would like to, say, for example, you're just a cholesterol member and you want to do blood pressure and diabetes all together, then you can register for those in one fell swoop. But you will need to register for this initiative.
Okay, great. Let's see here. We had a question for Dr. Weisshaar on slide 30. Let's see.
I'm here.
I'll get back to it. Okay, great. On that slide, you reviewed a series of suggestions for treatment. I think we're having a question here. If we could go back to that slide, maybe. I don't know if that's an option. But I think they wanted to just take a look at the figures. I will add that we have a copy of the slides available as a handout in your handout section. So if you want to review any of this information, you can refer back to that and get a little closer look at some of the details that we had. I think there was just a lot of really good content here, and so they wanted to get a closer look. So just remind,
it's a busy slide.
So I guess not a clinical question here, but we will have the slides available for you to download. Just a reminder, we are at the top of the hour, but you can still submit questions if you'd like, and we'll reply to you with any questions we weren't able to get to. Catherine,
is there a specific question on this?
I don't think so, actually. My apologies. I think they were just in the details of this particular slide. Okay.
And I will say one thing that I did notice, and I don't know if this is my view of the presentation or everybody's, but all of our slides that presented statistics, graphics, things like that, should have a citation at the bottom right. With this animation, the citation's a little blurry. If you can't see those citations and you would like to dig in a little bit more, please download the handout. I think what's happening is they're just getting cut off the bottom because they were right at that very bottom section. So please download the handouts. They're all there, as well as kind of an appendix of some at the very end, and that will help you kind of dig into some of these graphics as well.
We just had a couple other questions in general about how to join. You'll receive a follow-up email that will have a link to register. So you can take a look for that in about an hour. Everybody will receive a link. And if you have colleagues who aren't able to join today, that'll be in the email to all who registered. Catherine, I don't believe we have any more questions at this time.
Okay, well, I will just say one last time, thank you so much to Dr. Dana Weisshaar for presenting and really taking the time to walk us through some of the relevant science. It's always really great to hear how important an initiative like this is. We are really looking forward to engaging with all the organizations interested in this this new initiative. We can't wait to get your registrations and start. So thank you all so much for your time today, and looking forward to 2020 and the recognition cycle and improving patient care together. Thank you.
Thank you to all our presenters for participating in today's event. After today's webinar, you'll receive a follow-up email with a survey on the presentation. We'd love for you to complete that and provide your feedback. In the email, like I mentioned, you'll also have a link to register, and you'll receive a recording of today's presentation. On behalf of the American Heart Association, our presenters, thank you for joining us. Have a great day. This concludes today's presentation.